Hi, I'm Kathleen Jade with Natural Health Advisory, and I'm so honored to be here today with Dr. Patrick Donovan. Dr. Donovan is a naturopathic physician. He's been a naturopath for 30 years.
31, actually.
31 years. We're here now in his Seattle office. He owns an integrative medical practice here in Seattle. Dr. Donovan's been rated one of the top docs in Seattle. He has taught at Bastyr University. He's authored books. He's also an artist. And he's been one of my personal mentors, not only my teacher at Bastyr, but he's been one of my personal mentors and my healers. So I'm really happy to be sitting here today with him. Thanks for being with us.
It's a pleasure to be here. Thank you.
So let's get right into it. We're going to talk today about gluten.
We are.
And gluten is can be a really confusing topic for a lot of people. We've got so many different kinds of gluten disorders, gluten sensitivity, celiac, then there's wheat allergy. What's going on? How do we sort that all out?
Well, I think there are three primary animals, if you will, that get caught up in all of this. One we can sort of define right away and set that aside. That first one is gluten allergy. Okay. Gluten allergy is not celiac disease, and it's not gluten intolerance. Gluten allergy is an actual either IgE, immediate allergy, or delayed allergy to the gluten molecule, to the gliadin proteins. Mm-hmm. That is something that we just set aside for right now for this discussion.
Okay.
With a gluten allergy, you can have some of the same initial symptoms and such, but it's not destroying the gut like celiac really will do. And also with gluten allergy, you can't use gluten products topically because they'll cause allergic reactions. Mm-hmm. So we're going to set that aside.
Okay.
Then we have these two animals, if you will, that need to be characterized a little bit more, with a little bit more detail. And that is true celiac disease and gluten intolerance, with it, which is everything else that's not celiac that a person experiences when they eat gluten. Mm-hmm. Okay. And I think part of truly disentangling these and getting a little bit more clarity lies in understanding how the true diagnosis of celiac is now being proposed. What are the criteria to diagnose celiac?
Well, tell us a little bit more about that.
Well, the celiac clinics of America and of the world, actually, because there's some great celiac clinics in Australia and such doing this research as well. The celiac clinics now require a 4 out of 5 criteria be met to diagnose celiac. And here are the criteria.
Okay.
So 4 out of 5 means one of them can be thrown out. And most people will be surprised as to which one can get thrown out. Mm-hmm. Okay. So first of all, we look at criteria number 1. That first criteria is when a patient comes in with complaints, do those complaints, illnesses, signs, symptoms, are they associated with celiac disease?
Okay.
And that can be a huge group of disorders because, as we know, celiac disease is a major cause of leaky gut. And through leaky gut, we develop all sorts of chronic inflammatory autoimmune disorders. Mm-hmm. So there's a whole gamut of autoimmune disorders that can be associated with celiac. Some of the more primary are Hashimoto's thyroiditis, autoimmune disorders of all sorts, especially reactive arthritis and autoimmune arthritic conditions like rheumatoid arthritis, like lupus, etc.
Okay.
MS, even some of the neurologic disorders can be involved in that.
Okay.
So those are part of that first criteria. Mm-hmm. Also, the common things we think about with celiac disease: diarrhea, IBS, inflammatory bowel disease, cramping, abdominal bloating, reflux or GERD. So all of these things.
A lot of the digestive
symptoms, yes. Okay. Gallbladder disease, even pancreatitis is associated with celiac disease. So does the patient meet that first criteria? Any of these? Yes. Let's say we have yes. Okay, now we move on. Then we begin to question the patient. Are you better when you're completely free of gluten? That, folks, means strictly free of gluten. What does strict mean? There is no such diet as, well, I'm mostly gluten-free. Mostly gluten-free does not exist. You have to be strictly gluten-free. How long? Minimum of 6 to 12 weeks. I recommend 12 weeks before we can really assess.
Okay.
So second criteria, are you worse with gluten, better without? And that better without means strictly without for 3 months.
Yep.
A lot of patients will come in and they'll already tell you, oh my God, if I eat gluten, I'm a mess. So sometimes you can have that second one already determined.
Yep.
Third criteria, and here's where we begin to disentangle some things with gluten intolerance.
Okay.
Third criteria is looking at the genetics. There are primary genes associated with celiac disease, HLA-DQ2 and HLA-DQ8. These are two primary genes associated with risk for developing celiac disease. These genes are more primarily found in Irish, Scotch, Welsh, English, German, Italian, and Scandinavian. So these are high-risk groups to carry these genetics. So we can test for those genes. If we test for those genes and we find that this patient is a high risk for celiac, based on that, any one of many different combinations of those genes, if they're standing at, having a risk of 80% or 93% of having celiac sometime in their life, and they have all of the presenting symptoms or diseases that can be associated with celiac, and they're better without gluten and worse with gluten, folks, we're almost all the way home. We've just met 3 of the 4 criteria. What's the 4th criteria? The 4th criteria is, are there positive serologies? Now, what are serologies? Serologies are some of the antibodies that are associated with gluten intolerance or celiac. The 2 primary are deaminated gliadin peptide, IgA, and the second is transglutaminase antibody, IgA. If either one of those are positive, it's a done deal. It's celiac. Even if you don't really have some of the other criteria, that in itself is a done deal. Okay. But if you have built up all of those previous criteria and they're positive, and now you're dealing with a positive IgA, deaminated gliadin, or whatever, you've got celiac, folks. Now, here's where a big error is occurring, and it occurs every day in my office when I talk to gastroenterologists and other doctors. Well, that doesn't mean anything. Have the patient challenge gluten again so we can do a biopsy.
I hear that a lot, too.
No. Remember I said 4 out of 5 criteria need to be met. Guess which one can be thrown out? The biopsy can be thrown out. Why? Because we have since realized that you can have a negative biopsy and have full-blown celiac disease. How can that be? Because celiac disease is patchy, it's not confluent. And when you go in and you biopsy, you can't see celiac disease in the areas that you're biopsying. So you're biopsying randomly. And if you miss some of those patches, you're going to have a negative biopsy. And tell the patient you don't have celiac. When in all reality, the patient did have celiac. Now, on the opposite end, if the biopsy's positive, it's a done deal. It's celiac. But if the biopsy's negative, you cannot tell them they don't have celiac. Here's another point of contention and a point of error. Seroconversion. What does seroconversion mean? That means when you have antibodies to anything, it can take hours, days, weeks, months, and years in some cases to seroconvert, to develop that antibody, to get the levels high enough that it's positive. It can take up to 10 years to get a positive serology or a positive biopsy, a positive antibody in celiac disease. But during that 10 years, when you're developing that positiveness to that antibody, you're in full-blown celiac, meaning you're damaging your gut and creating more and more illness. So here's the metaphor. 1, you're going to take a trip. Let's say you're going to take a trip to Rome. And You've bought the tickets and you bought the chateau. You've paid for it already for 2 weeks. What's the likelihood you're going to Rome? Well, it's getting pretty big there alone. So that's like having the genetics positive. Okay. You've already got an investment. Okay. Secondly is the symptoms, signs and symptoms of celiac. Well, let's say you've got your bags packed and you're waiting for the airport or bus to pick you up and take you to the airport. That's evidence you're going on a trip. Well, the signs and symptoms of celiac are the evidence that you have celiac, the signs and symptoms associated with it. And then the positive serology is like you getting on the airplane. Well, you're still not in Rome, but you're getting on the airplane. And then the positive biopsy, if you will, is you're already landed in Rome. Now we can testify that you definitely are in Rome. So let's keep that in mind, and I'm going to ask you a question. If I know for sure your plane is going to blow up the minute it lands in Rome, when would you like me to tell you? Before you get on the plane? Because I would certainly like to know before getting on the plane that that plane is going to crash. So if I see that you have all the signs and symptoms and you're already developing disorders associated with celiac, that you're better without gluten, worse with, and you have positive genetics, that's enough for me. Because what's the risk of pretending you do have celiac? It's not great. It's not a great risk at all to be gluten-free. So there's no risk involved in surmising that I'm already well on my way to developing a serious illness that will create more and more disease the older I get. So at that point, I tell my patients, the likelihood of celiac is really high. Let's stop eating gluten. Now, we started this discussion because we want to disentangle the confusion between celiac and gluten intolerance. Here's the disentanglement. I think a lot of patients aren't having positive serologies yet, but have the positive genetics, have the signs and symptoms of gluten intolerance, and have the family history, the risk picture, all of that. And because they don't have a positive serology yet, they're not being defined as a celiac patient. So I think they come into this category of non-gluten allergic, non-celiac, but gluten intolerant, when really what they are celiac patients on the way to getting on the plane and landing in Rome. Okay. And so that's how I look at it and disentangle those.
Okay, that's interesting.
Yes.
So what kinds of symptoms, what kinds of patients do you end up seeing and diagnosing most often with one of these gluten-related disorders?
Well, one of the new studies that came out in the past year and a half, 2 years, was a study that was done looking at women with patients with Hashimoto's. Women have a tendency about 5 to 1 more than men to have Hashimoto's disease. So they looked at a large group of patients with Hashimoto's. They went back and they tested them. Now, remember, they were using the 4 out of 5 criteria, so they were looking for positive serologies as well. And they found that roughly 57-point-something%, so roughly 60% of patients with Hashimoto's disease had celiac.
Wow.
So celiac is a big risk factor for Hashimoto's patients. Now, if we took out the positive serology and used my idea of positive signs and symptoms, okay, better and worse, and positive genetics, meaning high risk, and stop there, I bet you we would see a lot more than 60% of patients associated with celiac disease who have Hashimoto's. So Hashimoto's disease, which is an autoimmune thyroiditis causing hypothyroid, one of the leading causes.
The leading cause of hypothyroidism.
Of hypothyroid.
Really,
Yeah. So that's one of the things. So now every patient coming through my office who has Hashimoto's, including children, we will screen for celiac.
Okay. Interesting.
All of the rheumatic disorders, it is advised in the peer-reviewed medical literature that all rheumatic, autoimmune, and reactive arthritic disorders be screened for celiac. Psoriasis, screened for celiac. Acne rosacea, screened for celiac. Asthma and chronic allergies, screening for celiac. Every child with eczema and/or asthma, especially early eczema. These are the kids that once they start to have food introduced and go on to a normal diet and stop breastfeeding will start to have some serious atopic dermatitis or eczema. They need to be screened for celiac.
Okay.
So these are just right off the top, and all inflammatory bowel patients. About 40% of Crohn's patients will have celiac disease underlying it.
Okay. And strict gluten-free diet for 3 months is what you recommend to really see how you react to gluten.
Yep.
How you feel off of it. What happens if you decide after that 3 months that you want to challenge it and see how you feel on it.
Exactly.
Okay. Okay. Thank you so much for sharing that with us.
You're welcome.
It is a really confusing topic for a lot of people, and I think this will help sort it out in people's minds a little bit.
I hope so. I hope so. And remember the 4 out of 5 criteria, please, because a lot of the specialists and a lot of the docs who've been practicing many years are still going by the old ideas. Only a biopsy, and that's not needed. That's really not needed now.
Good to know. Thank you so much for talking with us today, Dr.
Thank
Donovan.
you. It's a pleasure.
Really appreciate it.
It's a pleasure.